Okay, so I'm going to go ahead and get started. I'm going to thank everybody for joining us today for our second official CCHCSP session. Oh, sorry, wrong camera. It's this camera. So today we're diving into big data, where to get it, how to access it, and how to use it. And I'm very pleased and excited to introduce Dr. Eric Benchimol as our presenter today. So Dr. Benchimol is a pediatric gastroenterologist at the SickKids Inflammatory Bowel Disease Center. He's professor in the Department of Paediatrics at UT, senior scientist in the CCHRI, and correspondent at ISIS. And I'm just going to remind everybody to please put yourself on mute. Dr. Benchimol also chairs the Canadian Gastro-Intestinal Epidemiology Consortium, where he conducts epidemiology, pharmacoepidemiology, outcomes, and health services research using the health administrative data from multiple provinces to gain a national picture of IBD in Canada. Dr. Benchimol also has an interest in improving the methods used to conduct research using routinely collected health data. He co-chairs the Record Steering Committee, an international group which has created reporting guidelines for observational studies that use routinely collected health data for research. I'm also happy to say that Dr. Benchimol is an avid CCHCS skier. He had all 3 awards at the doctoral, I believe, career enhancement, and even I think PhD level awardee. And he also acts as the co-chair on our curriculum committee. So with that said, I'm just going to remind everybody again to put yourselves on mute. I'm going to see if
it's the person who's call-in user. Whoever you are, call-in user, a person who's not on mute.
Yeah, I'm going to see if I can do a hard mute as well. Oh, wait a minute. Are we good now? Mute. There we go.
Yeah.
Okay, so now we're good. So now I'm going to officially hand it over to Eric.
Thanks very much, Linda. Yeah, and I guess I am a CCHCSP lifer, right? Doctoral Award, then Career Development Award, then CEP, and now co-chair. So I have a lot to give back for, which is why I'm happy to give this talk today. All right, so we'll get right into it. I don't know how people usually do it. There's 30 participants, so it's a bit hard to ask questions in the middle of the talk, but I'll try to save some time at the end for questions as we go. So the objectives, I guess, were distributed before. It's really to give an introduction and describe the use of routinely collected health data for research, particularly in pediatrics, and I'll define what routinely collected health data are in a second. Provide some examples, and really the examples are going to be from my world, primarily inflammatory bowel disease, Crohn's and ulcerative colitis, and then identify strengths and weaknesses of using routinely collected health data for research. So first we'll define what routinely collected health data are. So they are data that are collected for a purpose other than research, right? So they're data that are collected for without a specific a priori research question in mind, typically through a variety of different methods or reasons. One is administration of the healthcare system. So those are the health administrative data that I primarily use for research. One is healthcare delivery. So things like EMR data, EHR data is considered a type of routinely collected health data. And monitoring of disease incidence and outcomes, so sort of registries and surveillance cohorts would be a form of routinely collected health data. And sort of some examples there, public health reporting obviously is an important part of data collection now in 2020. So we all know that Canada has really multiple healthcare systems, not just one. They are typically universal, single payer, government funded, mostly, some provinces more than other. They're administered by the provinces, and health administrative data are collected to plan the health system and conduct research. And we have access to them for research, really. It's important to note that because there's multiple healthcare systems, one in each province, we can't link, because of privacy rules, we can't link across the country unless you're using a national data set, such as CanGIEC's data set, the discharge abstract data. But for outpatient, for example, for outpatient data, you cannot link across provinces on an individual basis, but I'll show you a way that we've kind of gotten around that. In Ontario, the health administrative data are housed at ICES, and Linda, it's no longer ISIS. There was a rebranding exercise for obvious reasons. It's now known as ICES, so we have to call it ICES. And no comment beyond that. Anyway, so they started in 1992 at Sunnybrook, and they collected all the Ontario health administrative data, and you physically had to be on the site of Sunnybrook in order to use the data and do research with the data. However, since then they've expanded to multiple sites, really all academic sites in the province: Western, McMaster, ICES North in Sudbury, Queens, and Ottawa, as well as a ICES U of T at U of T on college in the IHPME building. So you can access the data there, and frankly, that's where the data analysts sit when they're there physically. But I think what's happened since March is really we've been able to do remote work almost seamlessly, and the analysts are primarily working from home. So, the sites, I think, are becoming less important in terms of the administration and the access of data. And we should be able to, once things open up, we should be able to access almost everything from home, with some privacy restrictions to people who are not assigned data analysts at ICES. So what's housed at ICES? There's a number of health administrative databases that are housed: OHIP data, so the physician billing data; medication data, although, as you know, in Ontario, we don't collect medication data on most people because most people are covered by private insurance. But if you're over 65, or if you're on Ontario Works and using Ontario drug benefits, we have the data for medications. Narcotics monitoring system as well for medications. So that's a mandatory reporting monitoring system for anybody on narcotics or stimulants. So things like ADHD medication would be in there. Hospitalization data from CanGIEC, so discharge abstract data, same day surgery. And the mom baby database is important for what we do. It links mothers' hospital records to the newborns' hospital records for everybody born in a hospital in Ontario. The registered persons database has sociodemographic characteristics, and then census data is there as well. And from these administrative data, we've been able to derive cohorts, sort of surveillance programs of different diseases, including cancer, diabetes, cardiac, and so on. And the one that I'm going to focus on, obviously, today is the Ontario Crohn's and Colitis cohort and how we derived it and what we did. And then other linked databases, more and more non-health databases are being linked in, and clinical databases, clinical health databases. So Born Ontario is now linked, at least in part, to ICES data. The NIDA was the precursor to Born, so that's all available. So those are maternal surveillance, pregnancy surveillance, as well as newborn clinical results from hospitals. Newborn screening is all there. Immigration data from Citizenship and Immigration Canada. There's some linked clinical data, like the Ottawa Hospital Data Warehouse with all the EMR data, as well as Emerald, which has primary care databases. First Nations data, transplant registries, and now lab results as well. And important that this OLIS lab system does contain the COVID-19 test results for the province. So we do have access to who was tested and the results. So what are strengths of using these sorts of data? This Venn diagram, I think, illustrates things perfectly. With large data sets, this is really a big data thing. You can get fast, cheap, great. You can get two of the three, but typically not all three together. It's almost impossible to get those three together. So the strengths of health administrative data are large populations. Typically, at least in Canada, they're population-based, because they collect everybody with a valid health card in the province, which is over 99% of the population. You can follow them longitudinally through hospitalization, outpatient, birth to death, as long as they stay in the province. They reflect what's really happening in the world. So it's not that sterile environment of a clinical trial or even an observational clinical research study. It reflects what's actually happening to these patients as they're treated by the healthcare system. They're fairly cheap. They're being collected anyway, and so they're cheap to access and cheap to use for research. You obviously couldn't collect this cheaply large amounts on 14 million Ontarians. So very nice benefit there, and they're fast, right? They're available anyway for research. You can access them at any point. However, there are significant weaknesses. So outcomes can be influenced by factors outside of health. So obviously we know about the social determinants of health, and unfortunately, until we have access to social data, social system data, for example, linked to the health data, that's kind of an unmeasured thing that we just aren't able to measure when you look at health outcomes using the health administrative data. That's getting better. I'll show you a little bit of, for example, Manitoba has done an excellent job linking Ministry of Education, Ministry of Social Services data to their health administrative data to start to incorporate that. Up until now, there's been a paucity of clinical data, but as I mentioned, with EMRs being increasingly adopted in different hospitals and in community practices, things like Emerald and the Ottawa Hospital Data Warehouse have really paved the way to integrating large amounts of clinical data with the administrative data, the coding. Cohort definition can be difficult, and I'll show you an example of what I mean by that in a second when it comes to the development of the Ontario Crohn's and Colitis cohort. And then importantly, coding accuracy, really subject to the garbage in, garbage out phenomenon. Physicians are notoriously they don't pay too much attention to billing. And so the diagnoses, billing is really intended to help reimbursement and not to tell people what diagnosis the patient has. So that you really need to consider validating the data before you use it. And we did this systematic review and developed reporting guidelines for validation studies using health administrative data. But in this case, I just want to sort of emphasize the findings of the systematic review in that, at least back then, and I don't think it's changed all that much, there are significant deficits in the way administrative data is validated prior to use for research, or at least the way it's reported. And there's a significant risk of misclassification bias, meaning bias in the research because you think that a patient has a disease, for example, when they really don't, or that they don't have a disease when they really do, and so on. And so again, validation is really key to using these data. However, despite this, the reality is these data are becoming increasingly available, and therefore they are becoming increasingly used. Unfortunately, GoPubMed.com was a nice visualization tool for PubMed. It no longer exists, but this is dating back to about 2017. You can see almost an exponential rise, looks like a COVID curve in Ontario right now. You can see an exponential rise in the numbers of studies that use routinely collected health data. In addition, they're becoming really increasingly international. This is a map of studies that have come out and what countries they've come out of using routinely collected health data. This is from 2010, and then this is from 2018. You can see really an internationalization of this type of research, primarily due to the uptake of electronic health records and the availability of the data through electronic health records in countries who didn't have it before. So that's led to the idea that we really need to become more transparent in the way we do research with these data. And so we developed these reporting guidelines, the reporting of studies conducted using observational routinely collected health data, after finding in a systematic review that really the transparency of the research using routinely collected health data is not adequate. Things like validation, things like code lists, and so on are not being reported in the studies, in the manuscripts when they're published. And so in 2015, we published this extension to the STROBE reporting guidelines, basically a checklist where you go through all the aspects of a study, an observational study, so not interventional, but observational, using routinely collected health data. And then you can check off the boxes to make sure that you've put your methods properly and transparently in the manuscript. And then in 2018, we expanded this to pharmacoepidemiology studies, so studies involving drugs using routinely collected health data published in the BMJ. So if you're interested more in the methodology of using these data as opposed to the practical use, I would urge you to read these two papers. I think they really provide a nice definition and what to look for and what to think about when you're doing this sort of research. But I'm going to focus more on practical use, like what we've used routinely collected health data for, and obviously use the example of inflammatory bowel disease, Crohn's and ulcerative colitis. As most of you know, Crohn's and ulcerative colitis are chronic immune-mediated inflammatory diseases, or IMIDs for short, where the immune system, basically there's a dysregulated immune response to something, we're not quite sure what, in a person who's probably genetically susceptible and then probably has an underlying established microbiome that makes the immune system trigger at some point in their life. I'm being very vague because frankly, we just don't know. We know that genetic susceptibility is a very low, a very weak cause of IBD in general. Environmental factors seem to play a large role, and the microbiome seems to play a large role, but we're still trying to work out exactly what causes these diseases. The two main subtypes of IBD are Crohn's disease and ulcerative colitis. And they're different. It's different than IBS. It's different than irritable bowel syndrome. Canada has amongst the highest rates of IBD in the world. We don't know why, but that's been repeatedly described since the mid 20th century, and it doesn't seem to be changing. Certainly, these are diseases of the Western world, so they rose very rapidly in the 20th century in Western Europe and North America, whereas in developing nations and Eastern nations, they were very low. The rates were very low. However, this is a systematic review of international studies, really did show it's becoming an increasingly international disease where probably Westernization factors are increasing the chance of people getting IBD in countries where it was previously low incidence before. So you can see that India seems to be a very quickly growing country for Crohn's disease and ulcerative colitis. So we're lucky enough with IBD that there are very specific ICD codes, International Classification of Disease codes, that go along with Crohn's disease and ulcerative colitis. You'll note that many diseases don't have good ICD codes, or if they do, they don't have good simple ICD codes that are used in the OHIP billing data. So OHIP uses a very simplified 3-digit form of ICD-9, whereas CIHI uses ICD-10 and the full form of ICD-9 and is much more specific. So it's hard in an outpatient disease to do surveillance or do research if an OHIP code doesn't exist, right? You're stuck with hospitalization data. But fortunately for Crohn's and ulcerative colitis, there are good OHIP codes, ICD-9 and ICD-10 codes. And so we wanted to develop a way of identifying people with IBD. In this particular study, it was really children with IBD, pediatric onset under the age of 18, using these codes. And so we developed an algorithm, and an algorithm is defined as any combination of different visits codes and so on, sort of physician billing codes, procedure codes, discharge codes, medications potentially. Any combination would be the algorithm. And we wanted to develop an algorithm, a combination of different codes that identifies IBD. So just like in any chronic disease, you can't rely on one visit to a doctor to know that you have a disease, right? So that's the same thing with administrative data. You really want multiple visits with potential investigations over a given period of time in order to know that the patient has the disease. And that's the algorithm. So an algorithm to validate it is similar to a diagnostic test where you needed a true positive reference standard cohort and a true negative reference standard cohort. In the case of pediatric IBD, we took the SickKids IBD cohort that was housed in a database and as the true positive. And because SickKids had the only pediatric gastroenterologist in the city of Toronto, as the true negative, we used every other child living in the city of Toronto at the time. And we essentially tested a number of different combinations of codes. The first thing we obviously did is say, well, what if you only have one, right? What if you only have one code for IBD, either a physician billing or a hospitalization? What's the likelihood of you actually having IBD? And the sensitivity was quite high, 99.5%, which means of the 183 kids with IBD in the database, I think 182 or 181 of them truly had IBD, and you picked them up. The specificity appeared high, but you can see here the positive predictive value is very low, which means that for the 183 children in the SickKids IBD database, there were over 2,000 children at the same time period that had a code for IBD, but were never seen in the SickKids IBD database, and therefore were in the true negative reference standard cohort. So the lesson there is really you need to validate. You can't depend on one code accurately identifying any disease, because you may have a lot of false positives and not even know about it unless you're validating. So this is sort of what we did. I don't expect you to read all of this information, but we kind of validated a whole bunch of different combinations. And this is just an example. We validated over 1,000 different combinations of codes. And we came up with one that accurately identified children as having IBD. And we used that algorithm to identify all children in Ontario with IBD. We also validated the algorithm in older children. So initially it was under 12, we validated in under 15, and then we went and reviewed charts across the province in the 5 pediatric hospitals, as well as community practices, pediatricians and adult gastroenterologists, to make sure that the algorithm worked in a setting that was not SickKids and Toronto, right? So we wanted to make sure that the practice patterns were the same, and therefore the algorithm worked, and it did. And then later on, we wanted to look at validating an adult algorithm, because that was specifically for pediatrics. And in fact, there have been a number of different algorithms validated to identify adults with IBD. And that's one of the lessons that I want to send to you. You can see that every algorithm identified in different places: Denmark, the UK, Manitoba, the Ontario pediatric one, Kaiser in California, they're all different, right? And that's an important message, that an algorithm validated one place may not necessarily apply to somewhere else. You can't rely on an algorithm that was validated in Denmark to work in Ontario health administrative data, because they all really functioned differently. And they all had different characteristics in terms of that diagnostic accuracy. So you really want to know how an algorithm functions in your own setting before you apply it to your own setting. However, it doesn't always work. I showed you an example of where it worked nicely, and it did work nicely for both adult and pediatric IBD, but it doesn't always work. There's a master's student, Jason Chan, who's now adolescent medicine, I think, somewhere, I think in Ontario, but I'm not sure where. And he wanted to look at biopsy-proven celiac disease in pediatrics and validate an algorithm. And you would think that if they went through a scope and a biopsy, the codes for celiac disease would be pretty good. And unfortunately, they weren't. They just, sensitivity-wise, 70%, you picked up two-thirds of them, but you can see the specificity and the positive predictive value are not great. And that's telling you that these kids are getting celiac diagnoses even after a scope that's negative. They're getting the diagnosis of celiac disease assigned on the outpatient side by someone, family doctor, nurse practitioner, whoever it is, even if they don't have celiac disease. And similarly, autism, you can imagine, is a tough diagnosis to make based on coding, because clinically the diagnosis is very hard to make. And not surprisingly, this study from Nova Scotia tried to validate autism diagnosis codes on the outpatient side and really could not find a code that worked to identify autism. So you have to be careful, right? You have to validate, but you may end up not being able to find an algorithm that works well. So let's talk about the Ontario Crohn's and Colitis cohort. So once we validated the adult, pediatric, and we actually had a separate algorithm for elderly people, we created a cohort of everybody living in the province with inflammatory bowel disease using those 3 algorithms. And we described the incidence and prevalence of IBD in Ontario over time, showing here that firstly, the peak onset is really in the 20 to 30-year-old age group. But the bar graphs show the change in the incidence over time in the study. And the study ran from 1999 to 2010. And you can see that the rise in the incidence was most significant and fastest in children under 10, followed by children aged 10 to 19. So the pediatric group was the fastest growing group of incident cases. It was also growing in adults aged 30 to 60, and the incidence was stable in older adults. So with that, we were able to, we've run quite a number of nice studies with Ontario data. However, you have to start to think that, yes, there's lots that we can do in Ontario. We're a big province, but Ontario may not represent the rest of the country. And you may want to know what's happening nationally with a type of disease research, as well as just locally in Ontario. And that's why we formed the Canadian Gastro-Intestinal Epidemiology Consortium, or CanGIEC for short, because we are all data geeks, and therefore that's how we named it. I didn't name it. I don't remember who did, but I thought it was a great name anyway. So we formed this group, and it's really a national group of epidemiology and health services researchers who are experts in using provincial health administrative data. And we looked at doing what's called a distributed network analysis of provincial data. So you remember at the beginning, I told you that you cannot link individual level data across provinces. They won't allow it. So they are saying, because of privacy rules, you can't link individual. And therefore we said, fine, what we're going to do is we're going to take the same code and we're going to run the exact same code in each province separately. And then we're going to meta-analyze the results in order to produce a national picture of what's happening with IBD in Canada. And this is an example of our pediatric incidence study, looking at the incidence of onset under 16 years old over time in 5 Canadian provinces. You can see that most of the provinces were around the same in terms of incidence, although Nova Scotia is a bit of an outlier. And Nova Scotia has been an outlier. We've known for the incidence of IBD in a number of studies dating back quite a while, both in adults and pediatrics. We're not really sure why. Different story. We can talk about that later. But this is the meta-analyzed results. So you can see where the Canadian pooled average is for standardized incidence. And this did demonstrate that Canada has amongst the highest, sort of the second highest pediatric onset incidence in the world. And then we were able to look at change over time. And you remember I mentioned that the incidence was rising most rapidly in children in Ontario over time when we did that study Ontario. And that's shown here that yes, in kids under 16, the rate was rising by about 6% per year of the study. It was also rising significantly in Quebec by about 3% per year in the study. But the incidence was stable in children in Alberta, Manitoba, and Nova Scotia. And so when we meta-analyzed the results, the rate change of 2.1% per year crossed zero, and therefore was not statistically significantly changing. However, because we had so many people, right, it's 5 separate provinces, very large population, we're able to look at age groups that we couldn't previously look at, because incidence in children under 10 is very, very rare. Incidence in children under 5 is even more rare. But because we had so many children, we were able to look at small age groups, 5-year age groups. And we found that the only age group with a statistically significantly rise in incidence were children under 5 years old, with the incidence rising by about 7.2% per year of the study. So that was a very important finding that got a lot of attention internationally. We've known for a while that this young onset IBD, what we call very early onset IBD, seemed to be rising, but ours was the first study powered to be able to show that it was statistically rising. So with this sort of national picture, we're also able to look at trends over time, as I mentioned, and start to use prediction models. So this study that was led by a PhD student in Alberta, in Calgary, tried to use ARIMA prediction models, similar to economic prediction models, to predict where the incidence of IBD was going in the next, up until 2030. And so this is the planned, this was a prevalence study. She's about to publish the incidence study, but this is the prevalence of IBD in, what is that, 7 provinces? 6 provinces, no, 7 provinces. And this is adult and pediatric. And you can see how she used actual data between anywhere from 1987 right up to 2010. And then she used that ARIMA regressive modeling to predict what was going to happen up until 2030. And she found that about 1% of the Canadian population would be affected with IBD by 2030. Right now, it's about 0.7%. And this is the prediction modeling for pediatrics. And you can see that the curve is rising very rapidly, with an expected prevalence in children of about 150 per 100,000. With that, again, a very impactful statement that 1% of the Canadian population is going to have IBD by the time 2030 comes around. That was used. We partnered with Crohn's and Colitis Canada to produce this report in 2018 called the Impact of IBD Report. And that formed the basis of really advocating to policymakers for increased attention and increased funding for people with IBD, as well as obviously advocating for donors and so on. And so this is an example of a slide that we use in our presentations to policymakers or to donors. And, again, when you say you've gone from 270,000 Canadians living with IBD in Canada right now to 403,000 Canadians living with IBD in 2030, it's a very impactful statement that gets a lot of attention from media and from policymakers. So it was a very successful partnership to take data that we've got from this routinely collected health data set to policymakers to say, these are the numbers. You need to start paying attention to IBD, which is typically as a stigmatized disease, right? When you talk about poop and that sort of thing, people don't want to talk about that. But I think the reality is that it's becoming an extremely common chronic disease in Canada, and we need to pay attention to it. So one of the other advantages that we have at ICES and the other administrative databases in Canada are that we can link between databases, and we can do that and examine things like health outcomes, burden on the healthcare system, as well as other outcomes or predictors, things like post-discharge outcomes. So you can link between hospitalization data and outpatient data, educational outcomes, as I'll show you in a second, environmental risk factors for diseases, employment and insurance, and so on. So lots of opportunity to look at things around the patient and around the healthcare system. However, error can be introduced through linkage. So in the same way that you have to validate before you identify patients, you really should be validating your linkage methods. And these are examples of good reporting that we used in the record reporting guidelines. And you can see you can report based on the Venn diagram, based on a flow diagram. It doesn't really matter as long as you're reporting who's successfully being linked and who is not successfully being linked, who's being left out of the cohort. But there's a lot of power in linkage. So this is an example of us linking the standard patient level health administrative data to the provider level administrative data. So knowing what kind of physician is treating the patient with IBD. This is for pediatric IBD. And we demonstrated that care is increasingly being provided by pediatric gastroenterologists, with decreased care to these children by adult gastroenterologists and by surgeons. And this was at the same time that surgery rates drop. This is an example of a transition of care from pediatric to adult care study that we looked at health services utilization before transfer and then after transfer. So obviously that's, you know, one of the weaknesses that we have when we do research with, for example, charts or observational cohorts in pediatrics, is once they're transferred to adults, you know, we kind of lose them. However, with the health administrative data, you can actually follow them along. And in this study, we took the Ontario Crohn's and Colitis cohort and we described health services utilization before and after. And we were able to describe an increased rate of emergency department utilization after transfer, not an increased rate of hospitalization or outpatient visits, which implies that these emergency department visits could be avoided, right? They didn't result in hospitalization. It's not that these kids got sick. It's that they probably didn't have access to care, outpatient care, the way they did in pediatrics, and therefore they showed up in the emergency room for their care. So that's a big issue that can be prevented with adequate healthcare. And similarly with transition, this is a study from Manitoba, which looked at linking their IBD cohort to Ministry of Education data and found that, you know, not surprisingly, if you know our patients, kids tend to do well. So when they had IBD, they had good outcomes in terms of educational outcomes. However, there were predictors of who had bad educational outcomes. Not surprisingly, having a mental health diagnosis and having lower socioeconomic status resulted in worse educational outcomes. So I might pause here for a second because I thought saw there was a couple of questions. Just trying to see. This one is a long one, so Derek, I might save your question for later if that's okay.
Yeah, I think he already stepped out. It's
Oh.
Linda, so that's a good idea. We can kind of hold all the questions to the end and maybe start off with his.
Sounds good. All right. So more linkage. So recently we were able to link immigration data, and we found that while immigrants to Canada had lower rates of developing IBD, again, remembering that people in developing countries have lower, although they're rising, they have lower rates of IBD than people in Western countries, developed countries. And we found that while immigrants had lower rates after they arrived to Canada, the earlier you arrived to Canada, the higher your risk of developing IBD. And you can see it's almost like a linear relationship here, where immigrants who arrived in the pediatric years had about 3.5 times the risk of subsequently developing IBD. And the older you got when you arrived, the lower your risk. And in fact, we found that the children of immigrants, remember I talked about linking the mom-baby database. So the mom-baby linked maternal and newborn in hospital births. So we linked the mothers who were immigrants to their children. And we found that children whose mothers arrived from certain regions, particularly South Asia, the Middle East and North Africa, Those were the two main regions. If they were born in Canada, they had the same risk of developing IBD as non-immigrant Canadian children. And similarly, immigrants from East Asia, China, Hong Kong primarily, had low rates when they arrived to Canada, and their children continued to have low rates even if they were born in Canada. And that implies some sort of genetic protection, or whether it's diet, we're not sure, more likely genetic because it was a very strong protection, that people from East Asia are much less likely to develop IBD, even when exposed to the Canadian environment early in life. And exposure to the Canadian environment earlier in life seems to predict higher risk of developing IBD later. Similarly, you look at air pollution. This is a study from Gil Kaplan, who did work with the UK THIN database, which is a primary care database collected from primary care practices, looking at nitric dioxide, sulfur dioxide, and particulate matter, markers of air pollution. And people, generally, there was no association between living in a polluted area and the development of IBD until you broke it down by age, where if you were exposed to air pollution early in life, you were more likely to develop IBD later in life. And in fact, if you were exposed to air pollution in your middle-aged years, sort of 44 to 57, it was protective. So there was an age effect there. And we know that environmental risk factors probably change your microbiome very early in life. And the microbiome is strongly associated with IBD. So Karen Matson took Dr. Kaplan's findings back to the basic science lab and used it as a sort of hypothesis generating approach, and found when she fed IL-10 knockout mice, which is a model of IBD, when she fed them particulate matter, they had an increased secretion of pro-inflammatory cytokines and decreased microbiome diversity, changes to the microbiome composition. And in fact, in a second study, she looked at feeding this stuff to mouse pups and found that feeding it to the mouse pup had a much stronger effect, and therefore early life seems to predict your likelihood of developing IBD, at least in this mouse model. So a nice example of where you can take these data, a finding that maybe you didn't expect, bring it back to a basic science lab and say, well, how can we prove that this hypothesis is true? Now, I think this air pollution thing is probably, the jury is still out. We actually looked at doing a similar air pollution study in Ontario just recently. This was from a master's student of mine, Michael Elton, who worked with Health Canada data and found that there was absolutely no association between ambient air pollution and the development of IBD, whether you were exposed early in life or whether you were exposed in utero. So we actually looked at pregnant women, and the children did not have increased or decreased risk of developing IBD. But more recently, he published a nice study that looked at the green space. So green space is a measure of your neighborhood taken by satellites. And you can look at where somebody grows up and see whether exposure to green space increases or decreases your chance of developing IBD. And he found a very, very strong association between green space as measured by the normalized difference vegetative index, or NDVI, and a protection for IBD. So the more green your environment, the less likely you were to have IBD. And that was even after controlling for air pollution, rural urban status, socioeconomic status, and other things. And in fact, that there was a dose-dependent relationship that was present in both Crohn's and ulcerative colitis. The more green the environment on a quartile basis, the less likely they were to develop IBD. We've known for some time that living in cities makes you more likely to develop IBD, but we don't know, what about the cities. And this may be a clue that it's exposure to the bugs, exposure to the sort of the microbiota that you get when you go to parks and when you have access to greener space, that then changes your microbiome early in life and protects you against development of IBD. So you can see potentially how we might use these data to advocate for healthy built environments and improve the environments that people who are at risk for these immune-mediated inflammatory diseases, not just IBD, but the others as well, we might be able to change their risk and lower the rates of IBD later. However, I talked a little bit about the weaknesses of these types of data. One major weakness is this issue of confounding. So just for the people who are not epidemiologists in the crowd, a confounder is a variable that affects both the predictor and the outcome, and makes it seem, if you don't know about the confounder, will make it seem like the predictor is causing the outcome, but in fact it's the confounder that's strengthening the relationship. So the classic example is coffee causing pancreatic cancer. We used to think that coffee caused pancreatic cancer. In fact, it was people who smoked were more likely to drink coffee, and people who smoked were also more likely to get pancreatic cancer, and therefore, clearly it wasn't the coffee, it was the smoking. So an example of an unmeasured confounder in IBD anyway, and in looking at transition from pediatric to adult care, is the issue of disease severity. So if we compared people who were transferred from pediatric to adult care to people who stayed with an adult specialist the whole time, there's going to be a confounder there, and that's disease severity, right? The more severe cases will probably go to the larger pediatric hospitals. And if you don't have clinical information in the administrative data, you can't measure disease severity. And so in all of our studies, the criticism you constantly get from the peer reviewer is, well, we just don't know anything about severity or phenotype or genotype or all of those confounders that might affect your outcome, and that might be also affecting the predictor. And so that's sort of the holy grail of administrative data research, right? Is being able to identify a way of measuring disease severity using the codes, using the health administrative data. And we're getting there. This study on the left was from Manitoba that actually did validate a way of measuring Crohn's disease severity using combinations of radiology and surgery and hospitalization codes and so on. And on the right is a measure of disease severity in Ontario for ulcerative colitis. So we're trying. They don't work great. I mean, that's the reality. Is I don't think they're ready for prime time. We're not going to use them in all our studies, but there are attempts to try to identify disease severity. I think the reality is linking EMR data will be the way to go, right? Being able to link clinical data will be able to help us deal with this confounder. Another example of an unmeasured confounder is smoking. So we don't have smoking status in our standard administrative data in Ontario. Even EMR data, as you probably know, it's not great in terms of knowing whether or not a patient is smoking. We've known for a long time smoking is the one strongest environmental risk factor for Crohn's disease. If you smoke, you're more likely to get Crohn's. If you smoke, you're more likely to need surgery for Crohn's, and your medications are more likely to fail. So one of my postdoc fellow, Ellen Kunzig, wanted to look at whether having asthma, so we know that having asthma is associated with IBD. So people with asthma are more likely to have IBD and vice versa, both ways. And the question is, if you have asthma, is whatever your immune system is it going on that it's causing an increased risk of surgery? But clearly smoking is the big confounder there, right? If you smoke, you're more likely to have asthma. If you smoke, you're more likely to have surgery. So what she wanted to look at is whether she could impute smoking status based on a clinical cohort and apply to the administrative data. So what she did is she took a clinical cohort in Alberta where smoking status was well documented, and she looked at who was smoker and who was not and imputed their characteristics on the health administrative data, and was in fact able to find very similar findings in terms of the association between asthma and surgery, that you were able to get basically the same result if you imputed smoking status versus not. Now, asthma was not associated with increased risk of surgery. You can see based on that hazard ratio there, but it was a nice example of imputing an unmeasured confounder based on clinical data linked to health administrative data. So let's talk a little bit about the future, and we'll kind of end off with the future of health administrative data research or routinely collected health data research. This is just where I think things are going, and then I'll take some questions. So I think, honestly, I think more linkage, as I've kind of implied, is going to be the future. We already have this sort of in Ontario, these data custodians, these Ministry of Health has given legal rights to ICES, newborn screening, to collect data on patients, on residents of the province, as well as to do research on those data in order to improve the lives of people living in Ontario. And so that's great. So you've already got a group of people who are custodians legally and have the right to both look at Ontarians' health administrative data and to even re-identify patients. And so you kind of have an area where you can link in clinical data like Emerald, which is the primary care EHR data from many different primary care practices across the province, and link it to ICES so that you have clinical data there. And yet the privacy officer for the privacy commissioner for the province knows that ICES will make sure that anything that comes out of that research will remain private and secure, and that Ontarians' privacy rights will not be violated. Similarly, we now have really 4 hospitals, pediatric hospitals in the province on EPIC. CHIO and SickKids are on a single healthcare instance of EPIC, so one data set. The Ottawa Hospital has just implemented EPIC. And I should say Blue Review Macmillan as well as in that Kids Health Alliance, CHIO and SickKids and Blue Review. And then McMaster is also going towards EPIC as well. And there are a number of different hospitals. So you can imagine that linking in this standardized group of EPIC data, EHR data, to this data custodian will further enrich what we have already. And then you've got a number of cohorts in my world of IBD. You have the Canadian Children IBD Network, which is an inception cohort of all the children diagnosed with IBD in Canada over a 5-year period. And then you have Imagine, which is adults with IBD and irritable bowel syndrome, IBS. And they were all consented to be able to link their clinical cohort data and their biologic data to health administrative data at ICES. And so, and I think it's in the range of 97% of people enrolled in these studies consented to that. So you can imagine the enrichment of biologic data from biologic specimens, microbiome, serum, and so on, and then looking at what their health services or looking at what their educational outcomes are using the population-based data for the province. So I think that's really the future of clinical research. Is many of these clinical studies will ask for consent to link to the routinely collected health data as well. I think machine learning is going to be a big thing going forward. It is a big thing already. I think ICES has been a bit behind with machine learning simply because of the resources involved in conducting the analysis and in the privacy concerns, because we can't send data out to the experts of machine learning. They're overcoming this with sort of cloud computing and other things. And this is a study that I'm doing with a PhD student who's not a ClinEpi PhD student. He's actually in the Telfer School of Management. They have an e-business program really in machine learning and AI. And he's going to start to look at building models to predict, based on early life environmental risk factors, to predict who will end up having an immune-mediated inflammatory disease, IBD, asthma, MS, arthritis, and so on. And you obviously need to validate that, but I think that's a tremendous step going forward in terms of having more advanced analytics, but also trying to identify associations, for example, environmental associations that our own human brains would not be able to identify. So I think that's going to be interesting going forward. But I think that, the reality is that AI sometimes ends up being a bit of a black box. We don't know what the algorithm is doing under the hood. And so it re-emphasizes the importance of being transparent and complete. And that's sort of where Record comes in, trying to make sure that people are completely reporting what they're doing and what the algorithms are doing so that we understand the strengths and the weaknesses of the study. And if nothing else, if we're complete with our reporting, at least we'll know whether the Skynet is taking over and whether the machines are going to take over the world. So with that, I just wanted to thank everybody. You can see here at the bottom that CCHCSP has been a funder for many years, as I mentioned. And I really want to thank Linda and Susan, before that, Nicola and Norm, for funding my career really up until just the last couple of years. So I really appreciate that. Thank you. And I'm happy to take questions now.
Thanks so much, Eric. We're very lucky to have you, I have to say. And I'm going to use this data to convince my husband to move back to Oakville with all the green space, so I appreciate it. So I'm going to start off while all the questions are coming in with Derek's comment to see if there's anything you want to add to it. He said, "Hi, everyone. Eric, this is truly an excellent presentation. I wish I had known about your validation work prior to embarking on an internal chart review based on ICD codes. Although on a smaller scale, we had to learn these lessons the hard way and frustrating way. Communicating with the decision support team was challenging as we spoke a different language in research. I continue to remain concerned about the validity of data shared with administrators and decision makers, given our experience in trying to identify diagnoses in this manner."
Yeah, I mean, I completely agree. I'll have one experience that I'll relay. And I think my message here is that us as data scientists have a responsibility to engage with administrators and policymakers and try to put the data into context. So the example that I'll give is from my previous hospital. It's a while now, 6 or 7 years ago. One of the administrative physicians came to me and said, listen, I know that you know data. I know that you know how to interpret the data. I want you to look at these trends in emergency department utilization and tell me what you think. And we went through different trends, different diseases, asthma and so on. And we get to a report that was given to the CEO of the hospital of mental health visits to CHIO. Oh, I just said what hospital it was. Oh, well. Mental health visits to CHIO over time, over the preceding 10 years. And it showed a curve that went like this. And it's not mirror image. It said mental health visits had dropped significantly, like 40% in the past 3 years. And I turned to the guy, I'm like, what is this? Like, I don't understand. And he's not a psychiatrist, he's not a pediatrician, right? So he's in the OR, he doesn't know what's happening out there with mental health. And he said, yeah, this is the codes we used. We used the big grouping of ICD codes for mental health. And this is clearly, obviously mental health is dropping. Isn't that great? I'm like, no, no, it's not great. It's not real, right? Clearly there was a mistake there. We all know that mental health visits to the emergency room have been rising for many years in pediatrics. And it's a matter of them not knowing what codes to ask for. And perhaps the coders in the hospital not being adequately trained to identify mental health visits. And maybe they were coding it as psychosocial problems or social problems, other ICD codes. So we never got to the bottom of what the problem was. I think though the message is that we have to engage, right? We have to go and help interpret these data. If you know how to use them, you kind of have a responsibility to help improve them and to interpret them. Similarly, I think we all have a responsibility to teach med students and residents how to code properly, right? I think they have absolutely no idea how to bill, which means that they have no idea how to code. And I think it's gotten worse and not better with Epic, like with the electronic health records, because Epic tends to interpret visits, interpret hospitalizations with diagnoses, and I have no idea where it comes up with these diagnoses. It may have been from a problem list 5 years ago, or a procedure that they went through 3 years ago. So a kid will be admitted with sepsis, and the most responsible diagnosis will be ear infection or something insane. So it's on us to kind of help med students, residents, house staff to understand the codes and make sure that they don't take it at face value.
Thanks, Eric. So I'm going to move on to BJ. Thank you for this very interesting presentation. I'm wondering how researchers access ICES and whether there are rules, procedures for linking a clinical database with their data set.
So there's two ways to access ICES data. One is to work with an ICES scientist. So the ICES scientist will help walk you through, how to link a data set, what REBs you need, if you need REB, because not all studies with ICES needs REB, how to go about doing it. And then ICES will assign an analyst to work with you and so on. So that's sort of the easiest way. It's probably the more expensive way as well, because that means that you're working with ICES analysts who are more expensive than maybe, somebody that you could work with on your own or hire on your own, or even a statistician who's doing the work for academic reasons. So they've also developed the Data Access Services Platform, DAS. So if you go to the ICES website, it's www.ices.on.ca, and you look up data analytic services. Sorry, I said data access services, but it's data analytic services. That is basically, was funded through a SPORE, one of the Ontario SPORE support units, funded by CIHR, to make data more accessible. So as long as you're based at a Canadian university, you can access ICES data. You put in the request, you have a consultation with one of their analysts. The analyst cuts the data for you just in a raw data set, and then sends it to you on a VPN, right? And you can do all the analyses yourself. There is a way to link clinical data through that platform. I don't think it's easy, and I still don't think it's cheap, because it does cost money to link. But if you put in your request through that platform, they will walk you through what is necessary, or even if it's feasible. I think the initial consultation is free, and then you can apply for funding if you need. But it's the difference between, just asking for a data cut and somebody actually doing the analysis yourself. So it depends on what you need, right? I think the advantage of working with an ICES scientist like me is that you're going to be aware, you're going to be made aware of the problems with the data and the methods that you can use to overcome those problems. Whereas if you're doing it yourself and you haven't been trained to do it, you may not be aware of it.
Thanks, Eric. Okay, so I'm going to move on to Elaine's question. Eric, great talk. I have learned so much. For the validation step, do you need to do that every time you extract data? Or once you've validated an algorithm, you can apply that algorithm moving forward? Just wondering if coding changes over time, making any algorithm outdated once published.
Yes. So, but you know, you have to balance that with feasibility and cost, right? I have not revalidated the IBD algorithms. They were validated in whatever 2009 and 2013, 14. And so theoretically, you know, I don't think there has been a major change in the healthcare system in Ontario that would result in a change in the way people are coded. But theoretically, there could have been. What's nagging at my mind here is when I validated the pediatric algorithm, we had very, very few cases under 6 years old, this very early onset IBD group. And it was an extremely rare condition, whereas now it's much, much more common. So I don't really know whether the algorithm works in that very young group compared to the older pediatric group. So it's kind of nagging at me that I probably should validate that very young group at some point soon. That being said, realistically, people tend to validate once, and then if there's a change, then you would revalidate. But you could go, you know, it's sort of a bit of a vicious cycle, because you could say, well, I'm doing another study with surgical outcomes this time. I have to validate my surgical codes. And then next week you're going to do a study looking at, I don't know, hospitalizations, and you should validate what is considered an IBD hospitalization as opposed to other types of hospitalization. So you could spend your life validating. The reality is, unfortunately, funders don't really care so much about validation. So you tend to have to work the validation into your funding for something else, some other project, and it's very expensive and time consuming to validate. So we kind of do our best, and you kind of have to evaluate, you know, what's the risk if you do not validate. So we're doing a study right now on surgical outcomes, and I used the codes validated in Alberta because it was done, and CanGIEC is CanGIEC, right? So it's national. So theoretically the codes should work in Ontario, but I didn't validate in Ontario.
So I'm just being mindful of the time. I know it's a minute after 1, but I'd like to get through a few more questions, Eric, if that's all right, and if
Sure.
everybody's willing to stay on, great.
One other thing to point out for Elaine's question is it also depends on what your outcome is, for example. So if it's like a surgery, it's a very hard code that's unlikely to be misclassified, right? Somebody's not going to misclassify. Like if you've had a surgery, somebody's not going to say you haven't had a surgery, because the coders will know that in hospital and the physician will bill for that. Whereas if your outcome is a weaker, kind of softer outcome, I don't know, I can't think of an example offhand, but you know what I mean? Like it's not as hard an outcome, then you're more likely to have misclassification. Sorry, go ahead, Linda.
No worries. So thanks for that, Eric. So I'm moving on to Peter. You validated the IBD data algorithm within Toronto and mentioned that this validation is not valid in other jurisdictions. How confident are you that the algorithm is valid across Ontario?
Sorry, I skipped through that a bit. If I had just left it at Toronto, I would not be confident. Toronto, obviously, SickKids treats patients very differently than a community adult GI would in Sudbury, for example. So we went across the province and validated. We went to actual practices and looked at charts in all sorts of different practices all across the province, as well as the other pediatric hospitals in Ontario. But when you look at something like RSV bronchiolitis, so we validated a way of identifying hospitalizations for RSV, and we took the CHIO charts as the true positive reference standard, because CHIO is the only hospital in Ottawa that will admit pediatric patients. We took every other child living in the city at the time as the true negative. And the likelihood is that CHIO codes for RSV bronchiolitis hospitalization very similarly to Toronto or even North York or Sudbury or whatever, that hospitalization code, if it works in Ottawa, it probably works elsewhere. So we were okay with that. But for IBD, I was not. And so we went, again, it's balancing feasibility and the risk of misclassification.
Okay, so now I'm going to move on to Janice's question. Thanks for an amazing presentation, Eric. A number of our trainees practice in fields where child-youth healthcare happens outside of the OHIP billing system and outside of hospitals. So for example, funded via Ministry of Children, Community and Social Services. Examples of this are preschool speech and language, infant hearing, and the autism program, and Ministry of Education. Can you tell us anything you know of attempts or plans to attempt linking these types of data with ICES?
Yeah. So the person to speak would be Astrid Gutman, who's the lead scientific officer for ICES. She's worked very hard to try to build inroads in these other ministries to link in data. There's a lot of work going on trying to, especially in pediatrics, because it's so, pediatrics is so cross ministry, right? Like it's so inter-ministry that it's very hard to get these data linked. But she is working very hard. It's happened in Manitoba. It should happen in Ontario, but it hasn't happened yet. It will hopefully soon. We're doing an infant hearing project, but we are using the infant hearing program. And because CHIO had all the data from the Champlain LIN for infant hearing screening, we just linked in the CHIO data to ICES. And so that's how we did it for the hearings to assess the effectiveness of the screening program implementation. So that's how we just had to link it in ourselves. But you're right that optimally it should be ministry to ministry or ministry to ICES, and that will happen. It's just been slow getting going.
Thanks so much, Eric. So I think that answers all the questions. There was a question from Olivia, but it sounds like it's already been answered. I'm just going to maybe open the floor to anybody who wants to ask one more question. Maybe they can unmute themselves. Going once, going twice. Okay, I'm going to say that's it for today. Thanks so much, Eric, for this fantastic presentation. A month from now, we're going to have a follow-up presentation on big data. And I should have the information in front of me, but I don't, so I will email it to everybody. Thanks again from everybody at CCHCSP and Olaf. So. Yep.
Olaf, nice. I have to say, so Stuart Nichols is giving that other presentation. Yeah, so he's an epidemiologist at Ottawa Hospital Research Institute, and we met. So he's going to focus on the ethics of using the data, privacy, transparency, more about the reporting than I've done. So it should be a kind of a different spin on using these data, more from an ethical perspective.
Thanks again, Eric. And thanks, everybody. So we'll see you all in a month.
Bye, everybody. Take care.
Bye.